Good evening and welcome to tonight's webinar on the Cerebellar Vermis, presented by Dr. Anna Monteagudo. After tonight's presentation, participants should be able to describe the normal anatomy of the posterior fossa and its contents and better understand the most common abnormalities. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this educational activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Monteagudo has no disclosures. During tonight's presentation, if you have questions for the presenter, you may submit them by typing them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Anna Monteagudo.
Good evening. Good evening, everyone. Tonight's presentation is going to be on the cerebellar vermis. The anatomy and to a greater degree pathologies involving the posterior fossa remain a challenge when scanning the fetal brain. It is true that when the posterior fossa appears abnormal, most practitioners are fast to refer the patient for a fetal MRI. This way, delegating to someone else the responsibility of making the diagnosis and of counseling the patient. This is probably due to many factors, the main being that in reality posterior fossa pathologies are rare, and even in busy referral centers, no more than a handful of cases are seen yearly. That said, MRI plays an important role in antenatal diagnosis of isolated Dandy Walker malformation, as it is able to find associated anomalies such as heterotopia and neuronal migration disorders that are difficult to find using ultrasound. It is impossible to discuss the vermis without first speaking about the cerebellar hemispheres and the cisterna magna. The reason is that since most pathologies affecting the vermis also disrupt the normal appearance of the above two structures. The posterior fossa is located between the Tentorium Cerebelli and the foramen magnum. It houses the cerebellum, vermis, fourth ventricle, cisterna magna, septum, brainstem, pons, and medulla. The Tentorium Cerebelli is the second largest dura fold after the falx cerebri. It separates the cerebellum from the occipital lobes of the brain. Attached posteriorly to the falx in the midline, it encloses the transverse sinus. Here is an image of a median plane of the fetus showing the Tentorium Cerebelli. You can see the entire tentorium between the arrowheads and the posterior fossa below. Now let's talk about the torcular. The Torcular Herophili, also known as the confluence of the sinuses, is the point where the superior sagittal sinus, straight sinus, and occipital sinus meet hence the name. Right here we can see it in this picture, and here we can see on the ultrasound in this median section. Again, this is a median plane showing the tentorium as well as the confluence of the sinus or the Torcular Herophili. So why are the tentorium and Torcular Herophili important? It's because their elevation is a sensitive indication of posterior fossa pathology. AIUM guidelines include imaging of the cerebellum, cisterna magna, and lateral ventricles as part of the minimal elements of the fetal anatomy scan. When normal, it has a high negative predictive value. The transcerebellar diameter doubles in size during the second trimester. Between 15 to 24 weeks, the 50th percentile equals the number of weeks plus or minus 1 millimeter. We can see in this nomogram published by Chavez in 2003 that the 50th percentile between 15 and 24 weeks is more or less the gestational age. The normal cisterna magna is seen in the second trimester, is stable in size. The mean size is 5 plus or minus 3 millimeters. Upper limit of normal is 10 millimeters. Failure to image occurs most often in fetuses greater than 30 weeks gestation. Cisterna magna septa seen in most fetuses during the second and third trimester. These anatomic structures are a result of normal embryologic development of the posterior fossa and represents the wall of Blake's pouch. Blake's pouch is a normal finger-like appendage of the fourth ventricle. Here we see the side walls of the Blake's pouch. Here we have the cerebellum. Its presence is a potential marker for normal posterior fossa development. To understand most pathologies that involve the vermis, it is important to review the highlights of its development. Let's talk a little bit about the early Vermian development, especially as relates to closure of the vermis. Robinson et al. Published in this diagram a representation of early Vermian development as seen by MR imaging of fetal specimen. In A, we can see the area of the vermis, the fourth ventricle, and the roof of the fourth ventricle in this particular study by MR was not well seen at the gestational age of 11 to 12 weeks and 13 to 14 weeks from the last menstrual period. As the gestational age progresses, we can see the fourth ventricle and its roof a lot clearer, the development of the fastigial point. At this time in the pregnancy, the brainstem has acquired a kink or the dorsal pointing flexion. As gestational age continues, at around 16 weeks from conception or 18 weeks from last menstrual period, the closure of the vermis occurs. In this particular event, we can see that the roof of the fourth ventricle covers completely. By 18 to 20 weeks, there is complete Vermian development. The vermis has reached its normal full development. Now let's take a look a little bit about the development as it relates to the fenestration of Blake's pouch. During the formation of the dorsal pointing flexure, as you can see right here, a transverse crease occurs, separating the roof into two parts, a superior or an anterior cranial or posterior or caudal membranous area. As development continues, we can begin to see the development of the vermis, the choroid plexus, and in the area that is going to become the future subarachnoid space, we see some cavitation occurring. Further development occurs, and we see that the vermis is completely formed, and the area below the vermis that is outpouching occurs into the area of the subarachnoid space. With further development, the outpouching into the subarachnoid space fenestrates, and the neck becomes the area of the foramen of Magendie. So Blake's pouch, as shown here, is a normal embryological structure that needs to undergo fenestration. Failure is a pathology. So now let's look at some ultrasounds. When scanning in an axial plane, a connection or a gap between the fourth ventricle and the cisterna magna may be seen between 15 and 18 weeks gestation. This is the gap that I'm referring to. This gap is known as Blake's metapore, as it contains the neck of Blake's pouch. Here we can see the Blake's pouch and the neck. Next we have an ultrasound depicting the same picture. Usually you can see this in fetuses at less than 20 weeks gestation if your ultrasound plane is semi-coronal. After fenestration occurs, this gap is known as the foramen of Magendie. So let's recap what I have gone over so far. Once Blake's pouch fenestrates, the metapore is known as the foramen of Magendie, typically seen in pregnancy less than 20 weeks when the axial plane is not perfect and the plane is somewhat semi-coronal. To avoid making this error, ensure the correct landmarks of the transcerebellar plane are seen. So now let's look at this. Which of these three scanning planes provides the most information about the vermis? So let's first look at the transcerebellar plane. Is this the right plane? The vermis is located between the two cerebellar hemispheres. However, in this plane, it is difficult to adequately image and evaluate the vermis. Its borders are not well demarcated. Now let's look at the coronal plane. Is this the right plane to image the vermis? In this plane, we see the occipital horns. We also see the tentorium, below which we see the cerebellum, and the vermis is located between the two cerebellar hemispheres. Similarly to the axial plane, the borders of the vermis are not well demarcated. So now let's look at the median plane. Is this the right plane? Yes, it is. The median plane allows easy visualization of the entire vermis. This is the vermis right here. So let's look a little bit more at the structures of the median plane. As I said earlier, it's the best plane to evaluate the vermis. The vermis is typically echogenic, and it's the most echogenic structure that you see in the posterior fossa, and it sits on the brain stem. Let's look even a little deeper into the structures of the posterior fossa. Here we have the vermis, we have the ventricle, and the fastigium of the fourth ventricle is this pointy or this peak. And the presence of this peak of the fastigium is a marker of normal development of the fourth ventricle. Here we have the tentorium and the area of the Torcular Cisterna Magna and the pons. So let's compare the axial versus the median plane as far as its regard assessment of the vermis. So in the axial plane, we can clearly see the cerebellum. The vermis we see here in the axial. However, in the median plane, we see the entire vermis in greater detail. The cisterna magna is seen in both. The fourth ventricle is seen in both. However, in the median section, we see the fastigium, or this peak, which is a marker of normal development of the fourth ventricle, and the brainstem is only seen in the median plane. So now that we have covered most of the basic anatomy, let's turn our attention to some of the anomalies that we see of the posterior fossa, especially those in which there is increased cisterna magna fluid. I'm going to discuss only four. The first one is Dandy-Walker malformation, followed by Mega-cisterna Magna, Blake's pouch cyst, and Vermian Hypoplasia. Of these four structures, pathologies, Dandy-Walker malformation is the most common, and the least common is Vermian Hypoplasia. So Dandy-Walker malformation we'll discuss first. The classic triad is complete or partial Vermian agenesis, cystic dilatation of the fourth ventricle, and large posterior fossa with upward rotation of vermis and elevation of the tentorium and torcular. When we're looking at an ultrasound in which there is increased fluid in the posterior fossa, there are three important questions that we should definitely keep in mind. And these questions are, is the vermis rotated? Is the torcular and tentorium elevated? Is the vermis normal in appearance and size? Vermian upward rotation and elevation of the tentorium and or torcular can be seen with conditions in which there is an enlarged cisterna magna. As we can see here in this example, the cisterna magna is enlarged and the torcular and the tentorium are elevated. Here we have the vermis. Conditions such as Dandy-Walker malformation, Blake's pouch cyst, and Vermian hypoplasia can result in both upward rotation and elevation of the tentorium and torcular. The degree of the rotation varies with the different pathologies. So the question is, can this rotation be quantified? There was a paper back in 2012 authored by the group of Volpe in which they looked at a couple of angles to try to assess this rotation. The brainstem vermis and brainstem tentorium angles have been used in the differential diagnosis of upward rotation of the cerebellar vermis. How are these angles obtained? The brainstem vermis angle, a line is drawn tangentially to the dorsal aspect of the brainstem. A second line is drawn tangentially to the ventral contour of the vermis. For the second angle, the brainstem tentorium angle, a third line is drawn tangentially to the tentorium. Using these measurements in the control group, they found that in normal controls, the BB angle is about 9 degrees, and the BT angle, the brainstem tentorium angle, is about 29. In addition, they went on to see how these angles perform in fetuses with posterior fossa abnormality. So in cases of fetuses with a diagnosis of Blake's pouch cyst, there was a small elevation of both the BT and the BT angle. In cases of Vermian hypoplasia, there was a little bit more increase in both the BB and the BT angle. And in cases of Dandy-Walker malformation, these angles were very increased, both the BB and BT angle. So let's look at this in a different way. The brainstem vermis angle can help establish if there is Vermian rotation. BB angle increases with the increasing severity of the condition. The BB angle greater than 45 is strongly suggestive of Danby-Walker malformation. And this is an example of Danby-Walker malformation. The brainstem tentorium angle can help establish if there is elevation of the tentorium and torcular. The BT angle, similarly to the BV angle, increases with the severity of the condition. However, there is significant overlap between the pathologies when using this angle. So what are the teaching points in relation to these two angles that I was talking about? The BV angle is an objective finding useful in differentiating posterior fossa fluid collections. BV angles less than 18 was always found in normal controls in the article that I just mentioned to you. BV angle increases with increasing severity of the condition. BV angle greater than 18 but less than 30 suggests a diagnosis of Blake's pouch cyst. BV angle greater than 45 is strongly suggestive of Danby-Walker malformation. The BT angle shows similar pattern, but there was much overlap between the groups. So now let's turn to the third question. Is the vermis normal in appearance and size? So the vermis has a primary fissure that separates the anterior lobe from the posterior lobe. There is a ratio of 1 to 2 between the anterior and the posterior lobes. The primary fissure of the vermis is very deep. Its identification suggests normal development of the vermis, although it does not eliminate other conditions. And this primary fissure is consistently seen after 24 weeks gestation. In this article from the group of Salet et al., they looked at the appearance of the Vermian primary fissure by gestational age, and they were able to identify as early as 18. And as the gestational age progressed, by the time the pregnancy was 24 weeks, they were able to identify this fissure in all the pregnancies that they studied. Now the next question that we need to address is the vermis too small? In the median plane, the vermis can be measured in two planes, in the cranial-caudal diameter and in the anterior-posterior diameter. And as you can see, there are tables here demonstrating the mean and the standard deviation of these two measurements. There is a linear relationship of the length of the vermis with gestational age. As gestational age increases, so does the length of the vermis. I just want to remind you that this is important because there are conditions such as Danby-Walker malformation and Vermian Hypoplasia in which the vermis, a small vermis, is seen. In addition, you can look at different nomograms, and you can see where the sizes of the vermis in relationship to the gestational age. If using 3D, you can perform all measurements of the vermis and the posterior fossa on a single acquisition. So let's try to put all of this together and develop an easy and simple method to diagnose Danby-Walker malformation. First, get the median plane. Second, answer the three questions that we were discussing a few minutes ago. Is the vermis rotated? Let's look at this image. Yes, it is rotated. The VV angle is increased. Is the torcular and tentorium elevated? Yes. The VT angle in this particular case is very increased. Is the vermis normal in appearance and size? Well, as you can see, this vermis is very, very small and hypoplastic. and really there's no need in this particular case to measure. But of course, if you're not sure, always it's good to go ahead and measure. So this is another example of a fetus with Danby-Walker malformation and agenesis of the corpus callosum. Here we can see the small vermis, the fourth ventricle communicating with the large cisterna magna, and the elevated tentorium and torcular. In another example, here we have the three orthogonal planes on this 3D volume, and we can see again that there is upward rotation of the vermis with an increased BV angle. The vermis is small, hypoplastic, and the tentorium is elevated. Here again is another example. We can see here in the coronal picture, we see the very large cisterna magna. In the axial, we see this displaced cerebellar hemisphere. And in the median section, we see the very small vermis, the enlarged cisterna magna freely communicating with the fourth ventricle and the elevated tentorium. As we spoke earlier about the closure of the vermis, occasionally when we are scanning, we see that there is a connection. So in this paper of Condro et al., they asked the question, is an open fourth ventricle prior to 20 weeks gestation a benign finding? In this retrospective review of 3D volumes, the role of the brainstem vermis angle in the diagnosis of fetal posterior fossa abnormality at 15 to 18 weeks was evaluated. So these are their results. In normal fetuses with a closed fourth ventricle, the DV angle was always less than 20. In normal fetuses with an open fourth ventricle, it had a similar appearance to Blake's pouch. The DV angle was between 20 and 40 degrees. And in fetuses that eventually developed Danby-Walker malformation, the DV angle was greater than 45. So the conclusion of this paper was that an open fourth ventricle is found in about 10% of normal fetuses at 15 to 18 weeks. Measurement of the DV angle is useful in these cases as a value of greater than 45 degrees is associated with a very high risk of severe posterior fossa malformation. So now let's turn our attention to the next condition, Blake's pouch cyst. In this condition, there is an apparent communication between the fourth ventricle and the posterior fossa. Typically, there is a normal vermis and Vermian fissure, and the fastigium is also normal. Palladini et al. In 2012 described 3 criteria for the diagnosis of Blake's pouch cyst. The criteria are 1. Normal anatomy and size of the vermis, 2. Mild to moderate rotation of the vermis, and 3. Normal size of the cisterna magna. In their paper, they also found that Blake's pouch cyst can undergo delayed fenestration at 20 to 26 weeks gestation in more than 50% of the cases in which they diagnose Blake's pouch cyst. Essentially, this means that this resolves by 24 to 26 weeks gestation. So let's look at some examples. And again, let's try to address the 3 questions. Is the vermis rotated? Yes. There is a large angle. Is the torcular and the tentorium elevated? Well, it's not very elevated in this particular case. Is the vermis normal in size and appearance? Yes, the vermis looks normal right here, and we can see another view of the vermis in this coronal section. Here in this coronal section, you can clearly see the walls of the Blake's pouch cyst. And in the axial section, we see the splayed out cerebellar hemisphere with the fourth ventricle. And here we have the walls of the cyst protruding into the area of the cisterna magna. Here's another example of a case of Blake's pouch cyst. We have mild rotation of the vermis, normal appearing vermis, and a normal torcular and tentorium. And again, this is another case at 29 weeks gestation. We have a normal cerebellar hemisphere. The vermis looks normal, and we can clearly see the walls of the Blake's pouch. If we go a little bit more inferior, we see the cerebellar hemisphere, the fourth ventricle, and the connection to the pouch. Again, here we see the cerebellar hemisphere, the fourth ventricle, connecting with the Blake's pouch cyst. In the median plane, we see the normal appearing vermis, which is normal in size. The fourth ventricle looks relatively normal, and we can see here the cyst, the Blake's pouch cyst. Here are the last two examples of Blake's pouch cyst. Here I have an axial section and a median section. Again, we see here the split out cerebellar hemispheres, the fourth ventricle communicating with the cyst. In the median section, we see the mildly rotated but normal sized vermis and the fourth ventricle connecting with the cisterna magna. Again, here in this other example, we see a normal vermis, we see the cyst. In the median section, we see the mild rotation, normal vermis, and the communication. This is an example of delayed fenestration or resolution of a Blake's pouch cyst. This is from the article that I talked to you earlier of Palladini. At 20 weeks, this fetus had a clear Blake's pouch cyst showing all the classical configurations such as the normal vermis and the connection between the fourth ventricle and the cisterna magna and the mild rotation. The patient came back and was re-scanned at 28 weeks, and at that time the vermis was no longer rotating, having returned to its normal position. Now let's talk a little bit about the Vermian abnormalities. This used to be known in the past as Danby-Walken variant. Vermian abnormalities can range from agenesis or total absence to hypoplastic but present but small. In isolated Vermian hypoplasia, the vermis is normally formed but small, and the posterior fossa is typically normal. Here we have an example. Here we have an axial section of a case of Vermian hypoplasia. We see the cerebellar hemisphere, the fourth ventricle that communicates freely with the cisterna magna. So once again, we want to ask our questions. Is the vermis rotated? Well, here we can see that there is some, yes, mild rotation of the vermis. Is the torcular and tentorium elevated? If we were to do our VT angles, we can see that there's some mild to moderate elevation. And is the vermis normal in appearance and size? No. The vermis, if we measure this vermis, is small, hypoplastic. Now let's talk about Mega-cisterna Magna. Mega-cisterna Magna is defined as a large cisterna magna measuring greater than 10 millimeters in the transverse cerebellar plane and a normal cerebellar vermis. Typically, there is absent hydrocephalus. In Mega-cisterna Magna, let's again look at our questions. Is the vermis rotated? No, the vermis is not rotated. Is the torcular and the tentorium elevated? No, it's not. Is the vermis normal in appearance and size? Yes, it's normal in appearance and size, but the vermis is very close, in very close relationship to the brainstem. So here we see an example of a Mega-cisterna Magna in an axial section showing the cerebellum vermis and the large cisterna magna. The same case in the median section. Again, we see the vermis, the brightly echogenic vermis in very close proximity to the brainstem, and the large cisterna magna. Up to this point, we have reviewed the definitions and the key sonographic findings in the four most common posterior fossa anomalies. Now I will review some important findings of a systematic review and meta-analysis that was recently published dealing with isolated posterior fossa anomalies. In this systematic review, it included 217 cases of Dandy-Walker malformation. Dandy-Walker malformation was commonly associated with both CNS and non-CNS anomalies, as well as chromosomal abnormalities. Ventriculomegaly was seen in 31% in about 1/3 of the cases. Overall ventriculomegaly before and after birth occur in 68% of the cases, and chromosomal abnormalities, of which chromosomal deletion was the most common, occurring in about 7.6%. Mega-cisterna Magna, isolated Mega-cisterna Magna, had a low association with CNS and non-CNS anomalies, as well as a very low risk of chromosomal abnormalities. Ventriculomegaly was seen in approximately 12% of the cases. Isolated Blake-Pal cyst had a low association with CNS and non-CNS anomalies, as well as chromosomal abnormalities. Vermian Hypoplasia was commonly associated with both CNS and non-CNS anomalies, but a very low association with chromosomal abnormalities. Diagnosis was not confirmed in approximately 32% of the cases. All of these cases were false positive diagnoses. Children with Dandy-Walker malformation are at an increased risk of abnormal neurodevelopment. As we can see here in this systematic review, the percent of children with neurodevelopmental abnormality and Dandy-Walker was 49%. Mega-cisterna Magna has a good outcome and small number of children with variable degree of neurodevelopmental delay. As we can see here in this graph, only about 14.9% of this cohort of 81 children with Mega-cisterna Magna had neurological delay. Blake-Pal cyst is a relatively benign condition with low rates of abnormal neurodevelopmental delay. And here we see that only about 5% of the cases had poor neurodevelopmental delay. In this systematic review, they had very few numbers of cases of Vermian hypoplasia. Therefore, it was very hard for them to extrapolate the outcome. But if we look at this small number of cases, about 30% of them had neurological outcome, poor neurological outcome. So, in summary, prenatal diagnosis of posterior fossa abnormality is not easy. The most common abnormality is Dandy-Walker. The axial plane alone is not sufficient to properly assess the posterior fossa. The median plane is essential. Also, please keep in mind the three important questions which should be answered when looking at fetuses with this condition. Again, to remind you, the questions are, is the vermis rotated? Is the torcular tentorium elevated? Is the vermis normal in appearance and size? In regards to the angles that we talked about, the VV and the VT angle, they can help in the differential diagnosis of posterior fossa malformation. Normal and cases of Mega-cisterna Magna, usually the angle is less than 20 degrees. In Blake's pouch cyst, the range of the angle is between 20 and 40. Vermian Hypoplasia less than 40. And in cases of Danby-Walker malformation, these are the ones who are going to have the largest VV angle, typically greater than 45. Once again, the greater the VV angle, the worse the diagnosis. So, in conclusion, this lecture is but the tip of the iceberg when dealing with posterior fossa pathology. The cerebellar vermis is a highly complex structure which we are just beginning to understand. The vermis holds the diagnostic key. Thank you for viewing this webinar.
It looks like we have one question coming in, which I'm going to send to you, Dr. Monteagudo.
Okay.
You see it now?
No.
Okay, let's see.
Questions, yes, yes.
Okay.
I have a, okay, I think I'm sorry, I have a hard time seeing the question. Let me try to make it bigger. Okay. The question is, cerebellum transverse diameter is useful for the assessment of fetal gestational age. Between which weeks is best to use? I would say typically between 18 to 24 weeks, no greater than that.
Okay, thank you for that answer. And it looks like you have answered everybody else's questions. So if there are no more, I'm just going to thank everyone very much for being here tonight. We hope you enjoyed tonight's webinar. Please remember to fill out the evaluation and the post-test. We hope you enjoyed the presentation. We'll join us again for future webinars. Good night, everyone. Have a great evening.
Thank you. Thank you.